Dr. Fred Heinzel from Infectious Diseases at USF, and today we're going to talk about the absence of spleen, specifically focusing on the immunologic and hematologic consequences of splenectomy. First off, what's the scope of the problem of splenectomy? The National Hospital Discharge Survey has numbers for this. It's estimated there's some 22,000 spleens removed every year. So there's a significant number of patients out there without a spleen. At the James A. Haley VAMC, we have an average census of between 12 and 15 asplenic patients at any given time. And about 7% of our polytrauma patients from OEF, OIF are splenectomized. So it's a real concern. And why do we really care about splenectomy? Most of you know this, and it has to do with post-splenectomy bacterial sepsis, which is one of the most rapidly fatal forms of bacterial sepsis known. This presents as an initial flu-like illness that escalates rapidly into bone infection, purpura, and shock. You can see some of the purpuric lesions there, particularly on the hand. It's not unusual for these patients to actually develop gangrene of the distal digits and extremities. It has about a 50 to 70% mortality, so that's something that kind of makes you stand up and pay attention. Now, post-splenectomy sepsis doesn't have to occur, and I just want to point out in this talk that the risk can be limited by appropriate use of vaccination and targeted use of antibiotics, and I'll discuss that more later on. But first, let's talk about the spleen. It's easy to get to the spleen. Basically, you go south down through the esophagus, hang left at about the duodenum, and you're into the spleen. One thing I do want to, I can't really point over there, I'm going to come right out, but point out that the arterial blood supply to the spleen, really it branches a couple different times. And this is going to be I'll talk a little more about this later in terms of how you can preserve parts of the spleen. You don't necessarily have to take the whole spleen out. And this is not to be confused with the spleen, aka Paul Rubens, and with apologies due to the makers of Mystery Men. And for extra credit, what was his special magical power?
He can fly.
He can shoot stuff.
Flatulence.
Flatulence.
Is it really?
You have to see the movie.
I want to see it.
Yeah, it's
I don't know.
to take off on, Fantastic Four and things like that. Anyway, fun facts for the curious splenophile. The spleen is an incredible immunologic factory for antibodies. It just cranks out antibodies in an efficient manner, focused to specific pathogens that it sees. About half of the body's immunoglobulin production occurs in the spleen. So you take the spleen out, I mean, you're really putting an imprint in the ability of the body to produce protective antibodies. In order to make those protective antibodies, the spleen uses both B and T cells working together in the white pulp to make sure that B cells are appropriately educated to produce long-lasting synthesis of IgG, and in particular to mature the IgG to the point where it has potent opsonizing principles. So opsonizing antibodies is what this is really going to be all about. You can opsonize two different ways, probably more, but let's just go with this. First is in the setting of infection, you can kill, they call it antigen here, but that's really a bacteria. You can kill bacteria by binding antibodies to its capsular coat antigens. And when you get enough antibodies there, they can activate C1q, which now nestles up to the FC portions of the antibodies. This then begins to trigger and assemble the classic complement pathway, and you punch holes through the bacteria and it dies. So that's a very important mechanism of containing infection. The other way to do this is that the antibodies then will bind to the same organism, possibly the same antigens on the surface, but through its FC portion, it interacts with FC receptors on macrophages and actually on a variety of different cells. And this then results in activation of phagocytosis and killing of the bacteria in the macrophage or the neutrophil. So you need both antibodies and white cells to really make the system work well. That's how we keep away from having burning around our blood all the time. Okay, so lysis by complement or ingestion and killing. The two different ways that you can kill bacteria by opsonization. You know most of that, I'm sure, from medical school. Some old histology of mine just pointed out that when you look in the red pulp, you've got some distinct domains. In the center, the blue part, those are lymphocytes, and those are B cells, mostly T cells in the center and B cells around the periphery there, because they all cluster around, and as antigens come into the system, they're presented by what they call reticular dendritic cells, which are cells that basically just stick antigens, and then they present it to the B and T cells. B and T cells then take apart the antigen, and then they can activate production of antibody directly against that specific antigen. And just pointing over here, then the red stuff those are mostly macrophages there, lymphocytes in the middle. And if you got other parts of the spleen, you also see a lot of macrophages elsewhere in the red pulp. Okay, so this again pointing out that as a T cell circulate through the body and B cells circulate through the body, they repeatedly pass through the spleen. They go through these penetrating arterioles in the lymphocytic sheath, the pals there, and with the they either the presenting antigens or the antigens are actually being distributed through the spleen, and so these T cells and B cells all have an opportunity to work together. All right. Now, beyond asplenia, there's another component of splenary dysfunction called hyposplenia, and that's more typically associated with hemoglobinopathies, classically sickle cell anemia. What happens there is you have these abnormal erythrocytes, including thalassemias. They tend to get stuck in the spleen because part of the function of the spleen is trying to filter out abnormal erythrocytes. And if you have a large burden of abnormal erythrocytes, you can actually cause engorgement, thrombosis of the spleen due to these abnormal red blood cells. So for sickle cell anemia, that can even result in thrombosis of large parts of the spleen, and they can be susceptible to bacterial infection. Splenic irradiation is used in the setting of preparation for allogeneic bone marrow transplantation or allo-SCT. And the total body irradiation probably, and the cytotoxic chemotherapy probably damages the white pulp and the red pulp to a significant degree. The macrophages are very resistant to irradiation, but the T and B cells don't tolerate that at all, which is why, of course, we use irradiation to kill lymphomas, because it's malignant T cells. There are other oddball things that cause hyposplenia. One is tumor infiltration, chronic myelogenous leukemia. Basically gums up the whole structure of the spleen, and you really don't have effective production of either new antibodies or old antibodies. Collagen vascular diseases, splenic infarctions, amyloid are other things that can happen. Okay, so as with asplenia, we still have the same problem. Hyposplenic patients are at risk for pneumococcal and Haemophilus sepsis. And with increased risk of about 6 months post-transplant. That 6 months seems to reflect the fact that in a transplant situation, patients are getting antibiotics for a long period of time. It's around 6 months that begin to peter off if the patient does well, and then they find out that they have to kind of monitor the antibodies. Here at Moffitt, often they'll be monitoring IgG levels in some of these patients. Okay, so the other thing that occurs in asplenia is you have some marked hematologic abnormalities. On one level, you can have atypical circulating erythrocytes, and they have some distinct morphologies, and they can tip you off to the thought that this person actually has an absent spleen. You have some amazing cell count perturbations, which is worthwhile knowing, because if you do see someone with splenectomy, you may be concerned about sepsis when actually the patient really has a fairly benign inflammatory condition. And the other is a prothrombotic state in a spleen, which hasn't really been well advertised, but actually is a significant problem of its own. Okay, so let's talk about the spleen as a hematologic filter, with the idea that it's going to clear out abnormal erythrocytes. Some 6% of the total cardiac output of the body goes to the spleen, and the spleen sinusoids turn out to be very efficient 1 micrometer filters. If you look at them in the capillaries of the spleen, they really have these like little bundles that are parallel and kind of have these annular fibers that kind of hold them together. So the pressure of the blood coming through this capillary tends to force the erythrocytes out through these little slits. It's essentially a filter. So you're filtering out the bad erythrocytes, and the other ones can go into the red pulp and continue to circulate. So in the setting of asplenia, you don't have this filtering function, and you start seeing some abnormal red cells. The most typical ones in asplenia are going to be Hal-Jolly bodies. These are basically erythrocytes that have these little black dots in them, single one, because these all represent a non-functional nucleus. Because normally the spleen would kind of pop out that old dead nucleus, since you don't need it in the erythrocyte once you've generated all your red cell proteins. So those are very typical and would suggest asplenia. You also get target cells and schistocytes. Target cells you're probably familiar with. And this is a very large number of target cells. And also the schistocytes with the little sharp pieces coming off of it are also characteristic of a spleen that isn't filtering anymore. And then the Heinz bodies, which are a little more oddball. Basically, those little bumps you see on the surface, those are denatured hemoglobin from a red cell that simply is becoming senescent. And if you stain with methylene blue or something like methylene blue, then they stain very intensely with blue. And so the pathologists and hematologists will be able to say that is truly a Heinz body. Okay, so let's talk about asplenia and leukocytosis. So we know about the abnormal erythrocytes, but did you know that the normal total blood count, white cell count in an asplenic patient may range between 14 and 20,000? They don't normally circulate in ranges you would expect to see. Part of that is because we don't have a spleen, and the spleen has an amazing capacity to store white cells, monocytes, and red cells and platelets. If you don't have a spleen, basically you're making these cells homeless, and so they're going to actually start going into the peripheral circulation. It's mostly PMNs, monocytes, eosinophils, not so much. Lymphocyte counts tend to remain normal because they want to stay in the red pulp and the white pulp, but they can also find a home in the lymphoid tissue throughout the rest of the body. You also see a relative thrombocytosis. Again, platelet counts may normalize in the 500,000 range on a good day. So if you see that, you can think either asplenia, or if you know that they're asplenic, you can look at that and say that's probably their normal range. Okay, now here's an example of a patient we had over at the VA in the spinal cord injury unit. He was status post splenectomy. Starting out on the left side here for the white count, which is kind of clipped up there. This patient developed a venous thrombosis of his lower leg, which in a normal individual could cause some fever, cause certainly some inflammation. This guy managed to drive his WAP count all the way up to 31,000. Came down again as his venous thrombosis improved, and then he had a hematoma because now he was anticoagulated. And the hematoma is also in muscle, is typically a fairly pro-inflammatory lesion. Once again, he drove that white count straight up, and eventually he was able to recover back to what would seem to be a fairly normal range there. The other cell that's going to vary extensively in the presence of even low-grade inflammation are going to be the platelet counts. And this same patient had a platelet count up into over the million range. Was even worked up for essential thrombophilia, but he didn't have it. That's a JAK1 mutation in the megakaryocyte, and there was no evidence of that. Okay, so this is all normal behavior for someone with no spleen. Lymphocytes turn out to be in the normal range throughout the whole thing. Once again, because they have another home, they can go into the lymphoid tissue that the platelets and white counts, the neutrophils can't do. Okay, so now on to the next topic, which is the fact that splenectomy leads to a persistent hypercoagulable state after trauma. That patient we just saw before probably is a good example of that. He had this deep venous thrombosis in a situation where he wouldn't have thought that was going to be an issue, but it's probably related to his splenectomy. Thrombotic complications are significant. There's an excess mortality of almost twofold from ischemic heart disease in patients with lifelong asplenia. There are also frequent venous and arterial thromboses and embolisms, with about a sixfold increase in atherosclerotic events, which I think were probably related to chronic recurring clot in the vessels. Now, this was compared to, and more importantly, if you identify patients with pulmonary arterial hypertension, you'll see that in about 11% of asplenic patients, which is a significant deviation away from what you normally expect to see with pulmonary hypertension. Again, suggesting that thrombosis from asplenia is causing that process. And it's thought that the erythrocyte membrane may be the cause of this, and this is really through Dr. Dahl and a few articles I dredged up. There's not a lot known about it. The thought is that the abnormal erythrocyte membranes, because these are abnormal erythrocytes circulating, that they may actually serve as a basis for activation of both clotting and the clotting cascade and also the thrombolytic cascade. So that's somewhat untested, but seems to make sense. Okay, so what do we do? So let's talk about post-splenectomy sepsis now. The highest risk for post-splenectomy sepsis in adults, we're going to talk about adults first, is in the first few years after splenectomy. About a third of the first infections occur within the first year, and half of the infections within 2 years. So the adult who has had a recent splenectomy is very high risk for infection. Asplenic children, particularly under 4 years, are at extreme risk. Part of this is not only because of the splenectomy, but they have a relatively immature immune system, which may or may not be modified by vaccination, though clearly vaccination is indicated. And lastly, the risk of infection in asplenic adults, in this case, persists for more than 15 years. So it's not necessarily lifelong, but it's something that's going to be with them for some time. And this is a retrospective study of some almost 6,000 patients over a 35-year span. So I think it's a very accurate picture of the state of the problem. Okay, so post-splenectomy sepsis it starts quietly enough, but then tends to amplify dramatically. Usually, it starts in nasopharyngeal colonization as a portal of entry. Almost all of the organisms causing this disease, the majority of them, are encapsulated organisms. Encapsulated organisms tend to have bind to sites within the nasopharynx, and sort of their process of moving towards a deeper infection. For instance, pneumococcus will appear initially in the nasopharynx, as will Haemophilus influenza, and certainly meningococcus can actually colonize the nasopharynx for some long period of time. So something happens that allows them to begin to show invasive behavior. So you have this short initial prodrome without an obvious focus. The patient just doesn't feel quite right, a little nausea, maybe a little bit of fever. And then this may merge into a sudden massive bacterium of encapsulated organisms with high mortality. The bacterium may associate with pneumonia, so there may be some focalizing infections, meningitis or endocarditis, but the net thing is it's overwhelming and dangerous. Septic shock will eventually will often result in disseminated intravascular coagulation. You have hypoglycemia, adrenal hemorrhages, and most survivors will have some degree of peripheral gangrene. Once again, mortality is high, 50 to 70%, and death usually occurs within a day or two. So even the best of physicians sometimes can't catch it early enough. There's also longer-term complications of asplenia that are a little bit different than what we just talked about. Asplenic veterans from World War II have a six-fold greater chance of mortality from pneumonia if they're asplenic. It's unclear if they have a higher rate of pneumonia or whether there's a higher rate of bacteremia resulting from the pneumonia. So there's a lot of health care burden associated with asplenia. The typical bacteremias are, of course, Streptococcus pneumoniae. They account for over half of the infections and death. Haemophilus influenza B, since most of the American public has been receiving the Hib vaccine in childhood, that's probably less of a concern. The same thing for Neisseria meningitidis with more extensive vaccination. Staph aureus and some streptococci also tend to fall into that category. So what can we do about preventing post-splenectomy sepsis? One possibility is to preserve the traumatized spleen, and this has been a big focus in the last few years, looking for alternatives to splenectomy. One thing you can do is splenorrhaphy, which is if there's a rent in the spleen, you can try and repair that tear using both absorbable sutures, and you can take a chunk of momentum and basically wrap it tight around the spleen, like an old blanket, papoose spleen, and it essentially will prevent bleeding from progressing. You can do partial splenectomies, and this is where the redundant blood supply to the spleen becomes important. Because if that bottom half of the spleen has a huge hole in it and it's bleeding inside the peritoneum, the surgeon can go in, he can dissect out that bottom part, because where you see the different arteries going into it, those have very defined territories with sort of fascial membranes around them. So they can actually kind of tease apart pieces of this little jigsaw puzzle and make sure that you still have some spleen left. You don't need a lot of spleen left because it will usually undergo a hyperplastic process later on, and you end up either having a bigger piece of spleen, or sometimes you even sort of see new spleens in that same area. Okay, so these are, I think, for the GI surgeon, this is something, a trauma surgeon, they pay a lot of attention to this now. Okay, and of course the other most important thing about prevention of post-splenectomy sepsis is routine childhood vaccination. I already mentioned that most children are getting appropriate vaccines that I think would serve them well if they have a subsequent splenectomy. And basically you use the standard CDC recommendations for children. Okay, vaccination for, I'm missing something. Maybe splenectomized adults, somehow that fell off. Okay, so for adults, and these are some evidence level graded guidelines for how to deal with splenectomized patients. Ideally, you should vaccinate with a pneumococcal, meningococcal, and possibly a Haemophilus vaccine prior to the splenectomy, if it's planned, and sometimes it is. If it's not planned and it's emergency, traumatic splenectomy, you can vaccinate at an appropriate time interval, which is usually 14 days after surgery. So either you're trying to do it 14 days before, 14 days later, and there's some low level of evidence, level 2, that this is protective for these patients. There's a level 3 thing here. It's also level 3 evidence. That doesn't quite fit with the other one. Okay, so you vaccinate ahead of time if you can, but within 14 days after surgery would also be considered appropriate. No one's really looking at conjugate vaccines for adults. That's almost always for kids, and there's no real CDC guidelines for using conjugate vaccines. You would probably just use the polysaccharide vaccines only, and until someone else decides to address that. So there may be an update sometime in the future. All right, so straightforward. If you can, save the spleen. At very least, vaccinate before or after splenectomy, and you should be in good shape. Other things you can do, and this is more of a British thing, they like to use antimicrobial prophylaxis or fever-initiated antibiotics. And there's some difficulties with this. One advantage is that the British, they love registries, and so all of these patients who have splenectomy, particularly kids, all of them are in a registry, and so they can go back and do some interesting analysis. The thought here is that for asplenic children under 5 years of age, if they have any a fever, asplenic children under age 5, it's not that if you continue them on either a year or maybe even lifelong treatment with penicillin or cephalosporins, that you'll reduce the risk of infection. And there's some evidence that it does indeed reduce the risk of post-splenectomy sepsis. Not great data though. What they do find though is that strong evidence that patients are very non-compliant with the medications, because if you look for penicillin in the urine, some 48% of the patients don't have penicillin in the urine, so they're not even taking the medications. So this has led to another approach, which is empiric antibiotics in response to fever, sort of just-in-time therapy. And one would be to keep on hand a stock of oral antibiotics. The idea is that take 1 or 2 of them, immediately go to an emergency room for blood cultures and evaluation and IV antibiotics if they think something's going on. And that's a little more what you're going to find in the United States, a little more practical. You don't have this business of people just using a whole lot of penicillin. And with also the problem of penicillin use on a regular daily basis, you always run the risk of driving up the MIC a little bit in a specific individual, which is no good. Okay, and there are even more registries. The Danish National Registry The best they could do is say that pneumococcal infection is reduced vaccination of asplenic children reduces the risk of infection, but there weren't great statistics with that. So there's a certain component of a belief system here in terms of vaccination, but I think in general the best thing to do is vaccinate. Antibodies are good, so keep them coming. All right, so there we have it, the spleen. And just a few major points: splenectomized subjects in higher risk for fatal bacteremia, greater for younger ages or recent splenectomy. Splenectomized patients are high risk for thromboembolic events, something that not a lot of people know, so hopefully that's something you're taking home fresh now. Higher white count and platelet numbers are normal in splenectomized patients, but they go through the roof if there's any sort of inflammatory response. So if you know your individual patient, you might be able to recognize what's a greater than normal increase. Risk in children can be reduced by adherence to the latest CDC vaccination schedules. Adults can be vaccinated before or after splenectomy. The efficacy in adults is a little less clear. Prophylactic or fever-initiated antibiotics may not be reliably effective. Okay, so this leaves you with the final problem of now you have a patient, maybe they have a fever, or they just have a rip-roaring leukocytosis more than you would expect. You have to evaluate the total picture if you think you're going to actually treat with antibiotics at this point. Symptoms, fever, obviously fever is a big tip-off. You're definitely treat for that. Culture results take a while. Procalcitonin is probably pretty useful in this situation. Patients with asplenia, their baseline procalcitonin doesn't seem to be any different than patients with spleen. So that's what I'd recommend to do. If doubt, treat with antibiotics until culture is negative, and suspect DVT or pulmonary embolism in the febrile asplenic patient because they really have a lot of problems. Okay, and that's it. Relatively short, hopefully to the point.